necessary. Now we even have vestibular evoked potentials which may help when you are dealing with recurrent episodes of isolated vertigo, which there is a wastebasket group which doesn't really fit into any of these matrices, in which certain of these investigations may be useful. We will deal with that in brief before I conclude. And this shows the algorithm of a pathway. So once you perform the clinic, this is a very busy slide, I won't go into all these details now. So the main thing is whether there is true vertigo or whether it is some other cause of dizziness. If it is true vertigo, are there neurological findings or no neurological findings? If there are neurological findings, then you go to the right hand side of the slide, otherwise you go to the other side. Then you perform an ear examination. If there are no neurological findings, look at the ear is normal. Are there auditory symptoms or not? If there are no auditory symptoms, do a Dix-Solpike maneuver. If it is positive, then it is BPPV. If it is negative, it may be something like a labyrinthitis or a vestibular neuronitis. If there are auditory symptoms, it is a Meniere's disease or a labyrinthitis. If not, it is a vestibular neuronitis. And you come to the other half of the slide on this right hand side, whether there is head trauma or not in the past or the recent past, no. Then you look for other neurological diseases, vascular, infection, demyelination and so on, tumors. And if there is history of trauma, then refer to the neurosurgeon. Even otherwise, if there is a tumor, refer to the neurosurgeon, he will take care of it. So that is the pathway that can be followed. And now these are certain conditions which do not fit the matrix which we saw. Migraine associated dizziness, which I just described to you. And again, another important thing is progressive disequilibrium of aging. Now this is a conglomerate of various abnormalities which come together. We will see that in brief. And cervical vertigo. So these are three common ones which we see. So what are the signs and symptoms in migraine associated dizziness? Usually with hemicranial headaches, or they may not be hemicranial, they may even be posterior headaches which may be seen in basilar migraine. And very often these people tend to have a disturbed vestibular function when you examine them clinically, and they have a greater predisposition to developing BPPV. And progressive disequilibrium of aging, this is a very common thing which we see in leave alone general practice, in neurological practice specifically. It is a multi-system decline, that is in the ear they have decreased hearing and they have decreased balance. Proprioception, not only arthritis like osteoarthritis, they may have a peripheral neuropathy because of diabetes for example, and they may have loss of joint position sensation, poor vision because of, so all input to the CNS afferents are decreased and therefore they will have disequilibrium. And besides that, in addition, if they have certain degenerative conditions in the brain like early extrapyramidal disorder or cerebellar degeneration, that does it, then that tends to worsen it or accelerate the problem. So how do we treat this? It is very essential that we recognize this problem as of aging and specific to the nervous system, and therefore we should stop vestibular suppressants and sedatives. The problems which are underlying should be corrected. For example, the patient has dense cataracts, it has to be corrected. If he has a diabetic neuropathy, at least the underlying cause should be treated properly. They should be given gait training and physiotherapy and other maneuvers to help them improve their gait. Cervical factors, I won't go into this in detail because I think Dr. Kripashankar will be dealing with some of these in his talk. And as an aside, is laughter really the best medicine? This is just an anecdote. A 63-year-old man was referred with 20-year history of syncope preceded by intense laughter, and the authors say that they were able to diagnose a gelastic syncope and laughter related syncope, and they treated him by advising him not to laugh so hard in the future, and when we saw him again he had been able to follow this advice. I don't think this will be very difficult given the current scenario in the world. It will not be very difficult not to laugh. And therefore, it is an easy form of treatment for such patients. So, in summary, what is the flavor of dizziness? So, like I said the earlier part, whether it is really say vertigo or not vertigo, what is the trajectory? It is acute, chronic, episodic, non-episodic, exclude medications, does it fit the matrix? If yes, then you can easily diagnose those four. If not, then it is obviously one of the other three. And if none of the above, then probably the patient needs a detailed neurological evaluation to look for other degenerative disorders which may involve the CNS. Certain pitfalls we should never forget. I thought the medication would help and not cause her to fall and break the hip. So very often in elderly people we should be very careful when prescribing drugs. I know it was vertical nystagmus, that there are no neurological findings, so I assumed it was peripheral vertigo. Never assume. This is a very important, especially when there is even a hint of vertical nystagmus. Always look for central involvement, central findings. I thought it was obvious that the patient shouldn't drive, especially when the patient is on drugs like Stemetil or any other suppressant. It is important that they should be advised not to drive for a few days or weeks, as the case may be. Vertigo has subsided, so I thought it was okay for him to walk to the bathroom. Just subsiding of symptoms is not mean that the patient will be able to resume all his normal activities early, because once they start moving, because of positional changes, they may experience an aggravation of symptoms. So they should be rehabilitated properly before they are allowed to undertake all rigorous normal activities. The patient was too young to worry about a stroke. Again, this is a classical example of things going wrong. I didn't know the patient had decreased hearing. So never forget to examine hearing in a patient who complains of vertigo. CT was normal, therefore I thought it was safe to send the patient home. No, like I said, CT is not always enough. The patient came from the psychiatric hospital, so I assumed he was crazy. Now that is the worst possible thing to do. Just because a patient has a previous history of some psychiatric disorder doesn't mean that he can't have vertigo or another neurological disorder now. Thank you.
Thank you so much, sir, for sharing the wonderful flavors of dizziness. Now we invite upon Dr. D. Kripashankar, sir, to give his presentation.
Morning, everybody. At the outset, I would like to thank Abbott and Professor Vasudevan, who is coordinating this program, for having invited me to briefly talk about post-traumatic vertigo. As Professor Vasudevan was talking earlier, it's a very common feature that is found, that we come across patients who have experienced even trivial trauma, suffering from dizziness, and sometimes we don't really care to give importance for the patient suffering, and often we miss out on an important problem like vertigo, which the patient has been suffering from, and this leads to the fact that the patient has to go from physician to physician searching a solution for his problem. Vertigo, as I told you, is a common symptom in individuals who have sustained major or minor head injury, and 90% of patients who have suffered a severe head injury experience post-traumatic vertigo, either immediately after the injury or even in a delayed form, maybe a few weeks or few months also later following the injury. So usually it follows road traffic accidents, falls, assaults, sports injuries. All these injuries, once a patient comes out of the injury, often, 90% of severe head injuries, often patients suffer from vertigo. What is the basic pathology behind this? What causes post-traumatic vertigo? It is, as Dr. Vasudevan was pointing out, is an injury to the vestibular system. The variability in trauma mechanism results in multiple possible anatomic sites of injury to the vestibular system. Signs and symptoms and treatment varies according to the injured anatomic structures. So you have to essentially know the history, and the clinical examination is very important in actually localizing where the injury has taken place and where the vestibular system is affected, so as to diagnose properly and give effective treatment to find a solution for the patient's problem. How does the vestibular system get injured? No, it can be due to neck injuries or it can be due to head injuries. Neck injuries, blunt injuries to the neck causes cervical vertigo. This terminology has now come to existence. Earlier, it was, during our probably times of when we were studying, this vaguely, we used to say that patients who have some trauma to the neck because they have spondylosis, maybe it is a cause for vertigo. But now, there are many papers that have come out which has proven that there is reason behind this vertigo occurring because of injuries to the neck. And head injuries. Head injuries can directly cause injury to the ears, or diffuse axonal injuries, which may involve the brainstem, thalamus, the temporal lobe, cerebellum, and just disturb the vestibular connections, which Dr. Vasudevan has already evaluated. What is cervical vertigo? It was described by one Professor Walter Sugar, a Chicago neurosurgeon. It follows whiplash injuries to the neck, injuries which cause hyperextension of the neck, occurs mostly in patients who have sustained cervical spine trauma or in those who already have cervical spondylosis. So very commonly seen following whiplash injuries, and especially more so in patients who have underlying cervical spondylosis. What are the features of cervical vertigo? Persisting symptoms. Persisting vertigo is uncommon in cervical vertigo, so the prognosis is good in case of vertigo which follows injury to the neck, that is cervical vertigo. This sort of vertigo, that is cervical vertigo, is often associated with neck pain and stiffness, and nystagmus is present in these patients. There is no tinnitus or hearing loss, and most patients recover spontaneously. So cervical vertigo, the main thing that you have to remember is these patients often present with symptoms of cervical strain, that is pain, stiffness of the neck, and often they resolve spontaneously once you treat this neck injury. What are the mechanisms of cervical vertigo? Arthritic involvement of the sympathetic plexus around the vertebral arteries. So the transverse foramen through which the vertebral arteries pass, there will be osteophytes in most patients who have, patients who have cervical spondylosis. Arthritic changes cause compression of these vertebral arteries and the sympathetic plexus around this, causing being the main reason for cervical vertigo, or altered tonic reflexes because of damage to the neck proprioceptors. Then cervical spondylosis, or stretching or tear of the vertebral artery can occur in trauma producing vascular disturbances. So especially more so, as I told you, in cervical spondylosis, where these transverse foramina are narrowed, so stretching of these vessels can produce ischemia and leading to vertigo. What are the types of vestibular dysfunction? Already, Dr. Vasudevan has gone through this. The peripheral vestibular dysfunction, central vestibular dysfunction, or both, mixed vestibular dysfunction. So these are common types of post-traumatic vertigo that is seen. We have because of diffuse axonal injuries, then post-traumatic migraine, epileptic vertigo, and post-concussion syndrome. We will go through all this briefly. Coming to peripheral post-traumatic vertigo, the most common is the positional vertigo, the BPPV, benign paroxysmal positional vertigo. 25% of these patients often give history of head injury. Clinically, the dizziness occurs or is brought out when the head is placed in certain positions, and the treatment will be repositioning maneuvers. Then post-traumatic mania syndrome, it's often also referred to as hydrops. There will be episodes of dizziness accompanied by noises in the ear, fullness, and hearing changes. Mechanism is often due to bleeding in the inner ear. Labyrinthine concussion can occur through direct injury. Labyrinthine disturbances or non-persistent hearing loss, only caused by head injuries. It is often difficult to differentiate from eighth nerve stretching clinically. Here is where VEMT may be useful in differentiating labyrinthine concussion from eighth nerve injuries. And temporal bone fractures. Often you have to do a CT scan to look out for any fractures, especially those involving the temporal bone. Transverse fractures are often associated with hearing loss and associated with Bell's palsy. There might be hemotympanum, blood behind the eardrum, and often it requires only conservative management for the patient to improve. Then coming to the central type of post-traumatic vertigo, brain injuries like diffuse axonal injury, which involves the brainstem, cerebellum, temporal lobe, thalamus. All this can cause vertigo, and patients have vertigo on recovery, and needs conservative line of management in most of these patients. Epileptic vertigo is a small group of patients suffer from this type of problem because of temporal lobe injuries, especially because it processes the vestibular signals. Patients have quick spins with altered conscious level. Treated with anticonvulsants, levetiracetam, which is the latest drug which is said to be useful in treating patients with epileptic vertigo. Post-traumatic migraine. Already Dr. Vasudevan has dealt with this. Dizziness or vertigo is combined with migraine headache. Migraine occurs in about 41% of patients with post-traumatic vertigo. Post-concussion syndrome. It often occurs due to blunt blows to the head. Sudden acceleration deceleration injuries can cause this type of syndrome. Patients often have vertigo, nausea, headache, and cognitive symptoms. Vertigo and nausea resolve early. Average within 6 to 8 weeks, you find that the patient has often come out of his vertigo and nausea problems, whereas the cognitive symptoms and headache takes a longer time to resolve, as much as sometimes it takes even 9 months for the problems to resolve. And how do you manage post-traumatic vertigo? Practically, you have to do a thorough clinical examination to localize the problem, to find out whether it is a peripheral problem or a central problem. A battery of neurophysiology tests are available in the form of audiometry, BAER, and VMP. Incidentally, I wanted to tell you about this VMP, the vestibular evoke myogenic potential, which is done for these patients in diagnosing vertigo, was first, in fact, instituted by Dr. Vasudevan. Many of us do not know that he was the first one to have introduced VMP studies in this part of the world, in Chennai, and he is one of the pioneers in though it is being done in many centers, Vasudevan stands to be one of the pioneers in VMP. Radiologically, you'll have to evaluate the patient with CT scan and MRI. You have to rule out and look out for fractures, contusions, or subdural hematomas. One thing I would like to mention here is this chronic subdural hematomas. Often we find that like chronic subdural hematoma, we often say that the patients, once they've had an injury, especially in elderly age group, they first CT scan is often normal. Few weeks later, they might complain of like weakness or headache, and you find that patient has got you want to do a CT scan to rule out a chronic subdural hematoma. Now you find that we have come across a couple of cases where patients have presented vertigo. At least the last 2 patients which we have operated recently, patients presented vertigo. They did not have any other symptoms, but only vertigo after a few weeks after injury. The first CT scan was normal, then they presented vertigo after a few weeks, and we found a CT scan. We did a CT scan to find that they presented. They had chronic subdural hematoma which needed evacuation. Going back into literature, I found that there were some cases reported wherein patients with after trauma they have present a chronic subdural hematoma, they have presented vertigo. So, how do you treat post-traumatic vertigo? Treat the cause. Rest for neck, especially in cervical vertigo, you have to give complete rest for the neck and probably immobilize the neck with a cervical collar. Labyrinthine sedative, cinnarizine, beta-histone, then habituation exercises, a police maneuver which Dr. Vasudevan has already told you about, and it needs to be done by experienced people. There are a couple of people, especially ENT surgeons, who are very well trained in doing this police maneuver very successfully. Surgery, posterior canal plugging procedures, which is done by the ENT surgeons, and I have mentioned this again, evacuation of STH, because often when a patient comes with vertigo following injury, you need to do a CT scan to rule out something like a subdural hematoma, which needs surgical management. Other drugs that may be useful will be paracetam, ginseng, methylcobalamin, and ginkgo biloba. Conclusion. To conclude, post-traumatic vertigo occurs following blunt trauma to the head, neck, and the craniocervical junction. Falls, whiplash injuries, acceleration, deceleration injuries can lead to post-traumatic vertigo. It occurs due to major impact on the vestibular system, can be treated with high success rate with appropriate diagnosis. Clinical neurophysiology tests like BAER, EEG, VMP have a clear-cut correlation with the improvement of subjective symptoms. So when you do this test, you always follow, maybe if the patient has had a brain injury, you do an EEG or you do a VMP, often they correlate. You find that the EEG improves as the patient's symptoms of vertigo also improve. Subjective symptoms of post-traumatic vertigo improved in about 4 years of time. So all that we need is we have to be very patient with the patient, give importance for his symptoms, because often this vertigo, the symptoms last for long duration, and you have to be very patient in treating the patients to find a solution for his problem. Thank you.
Now I request upon Dr. Muralidharan to give a speech especially on heart and the syncope.
For arranging such a wonderful meeting. Rather, it's a learning process to me. The last 1 hour I learned a lot of good points, and the way I know Vasu is always a great teacher, and the way he makes things simple, even complex phenomena. And I was watching one term when Vasu used, I belong to a field where investigations have become the rule of the day. I may be talking a lot. Vasu said, in the evaluation of vertigo, clinical approach is more important than all sophisticated instrument. But I think there is nothing more sophisticated than a human brain. And the heart, the entire job of the heart is supplying blood to the brain. In most of the time, that's the only job it does. And when that fails, syncope occurs. So it is just an interplay between the heart and brain, where heart is a simple slave to pump blood to the great organ brain. Is it working? Hope it works. Better. Okay. Okay. So the magnitude of syncope is quite enormous. In the sense, we have data mostly from the US, more than 1 million patients in the US and more than 500,000 patients per year. The problem is they do come only after the episode, and more than 6% of the admissions for dizziness or syncope and emergency room visits every year for many patients. And the problem is knowing what happened, actually what went wrong. That's the most difficult thing to know in the situation. I think there's something wrong with this presentation. So to begin with, I will show one important event I have come across in my cath lab. I like to see what the audience feel. That's going to tell us whether we are going to think of syncope. This is a 27-year-old guy who had a recurrent palpitation. We have taken him for a EP study, electrophysiology studies. What you see is the ECGs in the lab. We, halfway through the test, we induced a ventricular tachycardia. You can see that. Actually, we are so fortunate to make a diagnosis of ventricular tachycardia very easy when you have a electrode in the atria. So you see the atrial rate is very slow compared to ventricular rate. So the diagnosis of ventricular tachycardia was certain. Within seconds, he worsened, gone into polymorphic ventricular tachycardia and slipping into ventricular fibrillation. Promptly, we gave a shock. You can see that shock delivered and returned to sinus rhythm. So an episode where he developed VT, worsens the VT, polymorphic VT, ventricular fibrillation and shock. During this period, he became unconscious. We gave a shock, he regained consciousness. How many of you in this room think this could be a syncope or this can be defined as a syncope? Can you raise your hands? How many of you think this is a typical case of a syncope? No one. How many of you think this is not syncope? Straightforward question. Patient had a loss of consciousness in the lab. We have witnessed this is a problem also, and he had come only for this problem. But how many of you think this could be syncope? One. How many of you think this is not syncope? How many of you think it's neither? Okay. Anyway, I'll go forward. See, the reason why I showed this is to know not all unconsciousness or not loss of consciousness episodes